Welcome to everybody on a beautiful day. We haven't had a major rain in the state of Kansas, I think, in 3 months, so it was hard driving yesterday for me. I didn't know what to do. Delighted to get some rain. I want to first thank and recognize the team that's behind me, and particularly the Lieutenant Governor, Dr. Jeff Colyer, who has done a fabulous job on an extremely difficult topic that we're going to be announcing and putting forward today. You may recall when I first came into office, even before I was in office, I was talking about the needs that we had in Medicaid and to get Medicaid better organized, to serve the current constituency that gets Medicaid services, the same numbers at least or more, and to serve with better quality of service. But we've got to be able to hold our cost as best we possibly can. We put in this last budget year an additional $200 million, which we took from KDOT into Medicaid, and I stated at that time we don't have another $200 million this next year to do that with, and so we really need to look at the organizational structure and how we deliver this. The working group, including cabinet members and elected officials involved in Medicaid delivery to our state, has been working on this ever since. The input process, led by Lieutenant Governor Dr. Jeff Colyer, and the working group included stakeholder meetings and public forums held across the state of Kansas, and they were well attended. Our reform plan is based on 3 criteria: improving quality of care of Kansans receiving Medicaid, controlling cost of the program, and long-lasting reforms that improve the quality of health and wellness of Kansans. And we are serious about these issues. Everything was on the table. Our efforts were focused on choice, competition, affordability, and accountability as the working group worked to remake a 45-year-old program comport more effectively and efficiently with today's needs. Key to our success will be having the flexibility to reform the state's entire system of Medicaid to improve quality at lower cost. Improving quality at lower cost. I'd like to recognize a number of organizations and stakeholders who have joined us today and thank them for their valuable input during the process. Tom Bell with Kansas Hospital Association, thank you. Mike Hammond, Community Mental Health Centers, helped with this process. Jerry Slaughter with the Kansas Medical Society. Jerry, thanks. Rachel Monger, Leading Age Kansas, a nonprofit nursing home. Carrie Bacon, Kansas Council on Developmental Disabilities. Stacy Jones, owner of Helpers Incorporated and mother to a person with developmental disabilities. Jim Snyder with the Silver-Haired Legislature. Carlton McNair, president of the Silver-Haired Legislature. Janice DeBoer, Kansas Association of Area Agencies on Aging. Cindy Luxem, Kansas Home Care Association and Kansas Center for Assisted Living. Kathy Harding, Kansas Association for the Medically Underserved, and Kenny Wilk with the University of Kansas Hospital. And then finally, before I bring up Dr. Colyer, I want to thank the sub-cabinet who's here with me, all of which have worked very closely for an extended period of time on this most difficult organizational topic. They have really leaned into it. So Sean, Rob, Bob, thank you for the work that you've done in pulling together as a team. As I mentioned to them inside, we often talk about cooperation and then then fail to do it is the problem, because it involves a give and a take and a discussion and putting things on the table, and they all did. And they worked very well with their staffs together to put together what I think is an excellent product for us to be able to deliver the services across the state of Kansas effectively and efficiently. With that, I want to bring up the Lieutenant Governor, Jeff Colyer, to discuss the specifics. Jeff?
Thank you, Governor. Thank you, Governor Brownback. I think it was a very courageous thing that the Governor made his decision on. This is a program that affects 350,000 lives, and it affects the health and lives of Kansans. And the Governor said, take your time, do it right. Let's go and make this a better program for all Kansans. And with that charge, we've spent the last 9 or 10 months working diligently across a lot of different cabinet agencies. And the 3 gentlemen with us, Dr. Mosier, Rob Seidlecki, and Sean Sullivan, they've made a tremendous effort, and it represents a large effort within your agencies as well in order to come up with a program that we believe will move the state forward. The problem for the state of Kansas has been, we've had a lot of problems that we've had to deal with. One of those is, how do we get better quality of care, better outcomes for Kansans overall? We also know that Medicaid has been growing at a 7.5% rate of growth over the last several years, and that's unsustainable. At those sorts of growth rates, we're already feeling crowding out of education and other state programs. And so we put together the sub-cabinet group in order to work this process overall. And we put together a stakeholder process which was made possible by a grant from several foundations, and we'd like to thank them for that opportunity, as the Healthcare Foundation of Kansas City, the Kansas Health Foundation, the REACH Healthcare Foundation, the Sunflower Foundation, and United Methodist Health Ministry Fund. The stakeholder process went on across the state, and we had over 1,700 Kansans show up at a variety of forums across the state to discuss Medicaid. We had over 2,000 ideas and comments that we have sifted through and used. Many of these additional things that we had were a web-based survey, population-specific stakeholder groups, and a final wrap-up forum. And whenever possible, we have met with all stakeholders, and we have never turned down a stakeholder meeting, and that process will continue. We enjoy that opportunity to work together. In dealing with this, we had several principles for reform. And the number one principle is improved outcomes and better health for Kansans. We want to, secondly, make sure that we have integrated care for the whole person. And what we discovered in those healthcare reforms is that Kansans were finding their healthcare was being divided up in a lot of different cabinet agencies and programs, and that we needed to look at the whole person. The third one is that we need to make sure that we stabilize the safety net in the long term. And we need to make sure that we have every opportunity for private health care, but we want to make sure that the government finance programs that we have are stable and as a stable safety net. The next principle was we looked at a number of lessons from other states. We looked at the state of Missouri. We will not cut off hundreds of thousands of Kansans from our Medicaid program. We're going to preserve all of those eligibilities that are there. Another lesson that we learned was from California, that we were not going to have large provider cuts across the board that could damage health care and would not encourage quality. And so we've taken those items completely off of the table. The other issue that we have to deal with is what's going on with the federal government. The Obama administration has announced at least a $72 billion cut to Medicaid over the next several years, which translates into roughly about a $720 million cut to Kansas Medicaid over the next few years. And we've got to get ourselves in a position to deal with that reality. And then finally, we want to make sure that we're encouraging personal responsibility and discourage dependency and make our programs more economically rational. So a variety of solutions have come together, and we're putting those together here. The first one is our dealings with the federal government. We will have to ask for a federal waiver. The state of Kansas will be asking for a global waiver from the federal government, so we have continued flexibilities in administering our Medicaid program for all Kansans. We will also be asking for some interim aspects of that in order to enable the program that we have right now. The second major aspect of this will be a person-centered care coordination, integrated care. What we are going to be doing is aligning the financial incentives for payers, providers, and consumers to best serve the needs of the whole person and the taxpayer without adding to the administrative burden of the program. This is a very personal aspect to me and from dealing with my patients over the years. It is not just one particular health problem, it is the whole person. How do we get Kansans to have the full independence that we all desire? And so we will have an integrated program, and that integrated program will be called CanCare, K-A-N-C-A-R-E. And that'll include all major populations, all services, everybody is involved. It is a shared opportunity for us to have integrated care for the whole person. What we will be doing is targeting 3 statewide CanCare contracts that would be statewide to serve all services there and provide some competition. We currently have 2. Next pairs our population-specific and statewide outcome measures with meaningful financial incentives. We want results, and we're willing to put money on the line to achieve those results. And that is going to be a major driver and a major shift in the Medicaid program. The third item is that we'll be creating health homes with an initial focus on individuals with mental illness, diabetes, or both. The next major item will be that we want to use the established community partners that are there, hospitals, physicians, CMHCs, primary care, safety nets, the SILs, the area agencies on aging, and the CDDOs. We all want them to continue their services and to have that in a coordinated fashion and to continue to rely on the strengths that they bring to the state of Kansas. We will also have a number of safeguards for provider reimbursement and quality to make sure that we're not seeing across-the-board rate cuts, but that we're trying to drive quality and long-term results and spur long-term investments in the program. And then finally, we will be having contractual obligations to maintain existing services and beneficiary protections. So we're not going to have major benefit cuts. The next item in the program is that there will be some off-ramps from Medicaid. Now, our reforms are really how can we transfer patients or Kansans back to their private insurance, those who want to have a job. And so you will see something like a COBRA-like option as people leave CanCare. There will be an opportunity for health savings accounts that could be used to pay for private sector health insurance premiums. Another aspect of this is the opportunity for work. When we went around the state with 1,800 stakeholders, one of the things that we heard universally is that people want to work. They don't want to be trapped and be dependent in their programs. And so we are very excited about our work program. It will lead to happier and healthier Kansans. They'll have more fulfilling lives. And so the goal is to transition people from Medicaid into the private sector wherever possible. And so we will have an enhanced Medicaid to Work program in collaboration with the Department of Commerce to match potential workers and employers. We'll also be reducing disincentives to work, creating a disability preference for state employment, leveraging state purchasing and incentive policies, and establishing incentives for businesses that hire people with disabilities. We're also going to be increasing awareness of the use law. All of this is going to require pretty fundamental shifts, not only in the program, but in the way that we govern. And the state is going to be asking providers to change the way they do business to improve outcomes. We're doing the same for government. We will be changing the way that we do business. And we are going to be proposing a realignment of state agencies to better reflect the needs of the state and to streamline our services for the customer under the new CanCare system. The details of the move are going to be provided, but the general outline is this. The Kansas Department of Health and Environment will remain as the single state Medicaid agency, and it will have the financial and contractual management functions, and we will consolidate that within its responsibility. The Department of Aging will absorb the HCBS waivers, mental health programs, as well as the state hospitals, and become a one-stop shop for all long-term care functions. So the Kansas Department of Aging will be renamed the Kansas Department of Aging and Human Services. So we have one agency that can coordinate the care directly with all of those programs. Next, SRS is going to add select family preservation, social prevention programs from KDHE and juvenile justice. It's going to focus and target on children and a family services agency. And its focus will be squarely on those issues related to children and family welfare. So SRS will be renamed the Department for Children and Families. Finally, there's savings. Based on a conservative estimate, we went and we've looked at, historically, we are looking at a 7.5% annual growth rate. If we look at a more conservative growth rate, this package is projected to save at least $853 million in all funds over the next 5 years. When you include the policies the administration has already implemented, such as electronic visit verifications, the savings are even substantially higher. We will give you an exact breakdown in your handout. All of these are savings while not cutting people from the program, not cutting benefits, or slashing provider reimbursement rates. We're doing it by better care for Kansans. And that is the whole goal of this. Medicaid is a very complicated piece. It is a Rubik's Cube. And we've spent a lot of time trying to put that together. And the governor instructed us, don't take the stickers off the Rubik's Cube. Let's get it right. And we will now have a program where we can administer this and work and really target our patients.